What other types of blood work do you run when assessing a patient? So prolactin is not one of the markers that is typically recommended in MCAS at this point in time. And when we talk about looking at things to diagnose a condition, we're always looking for tests that are as specific and sensitive to the condition as possible. So certainly a high prolactin level needs to be evaluated for the most common causes of that. And nobody would confuse me for an endocrinologist, but I think that would be the route I would pursue if that was something that, you know, one of the participants was experiencing. And hopefully, at least if you go through the flow diagram that I had put together, you can see the tests that are often suggested by people who have expertise in MCAS. Certainly not all of those are available, as I already mentioned, and certainly even in my neck of the woods, which is a more rural part of Ontario, I don't have access to anything more than tryptase and chromogranin A. And as I mentioned, tryptase is very rarely elevated unless we get one as a baseline and then look for a flare in the emergency or flare context, which is very difficult, as I mentioned. So, and chromogranin A, just as a comment, is not a very specific marker. So you do actually, it's sensitive perhaps, but it's not specific. So you have to rule out other conflicting or possible diagnoses before you can really rely on that. But the consensus is that really we should have 2 laboratory markers. So that makes it a little bit tricky. So I hope that answers sort of the blood work question. And there's a lot more details, particularly in the consensus 2 paper that I think is helpful for clinicians. Question number 2 is, what are the clinical signs that indicate an assessment is warranted for MCAS? So hopefully I've described that. Now, certainly there's a lot of other conditions that can masquerade in a very similar fashion. So, you know, any clinician should do their due diligence. I would say that it's not a diagnosis of exclusion. So it's not the default if we've ruled everything else out. If the shoe fits, it fits. And often we spend a lot of time chasing, you know, some very obscure diagnoses before even considering this, if it's on the radar for the clinician at all. Question number 3 is, what other conditions should be ruled out, or what testing should be done prior to a referral for an assessment for MCAS to be made? So, for example, are there other conditions that the symptoms mimic or that it could be confused for? So this is an Ehlers-Danlos Syndrome conference, and the first speaker highlighted rather clearly that there is a high degree of comorbidity of MCAS in the Ehlers-Danlos Syndrome population. And certainly anybody who comes to my office with symptoms that sort of smack of that, it is challenging. I feel like I even struggle when I have patients that present with features that are more one than the other, or do they perhaps have both? It's not easy. And I think I'm learning as I go. I learn from my patients and I read up on this continuously, and it's going to take some time because we are in early days. Now, otherwise, I always look for any possible autoimmune sort of conditions. So certainly I don't want to miss something that could be rheumatoid arthritis or psoriatic arthritis, lupus, because a lot of times patients will have sort of that feel of an autoimmune disorder. Maybe they've had an elevated inflammatory marker like ESR or CRP in the past, but then it was checked again and it was normal. Patients may even have had a positive ANA, which is a screening test that we use for some of those rheumatological conditions, and then another time they won't. So there's sort of like a flavor of grumbling autoimmunity, but we should still make sure we're not missing those. And otherwise, really, I guess, doing a head to toe and screening each system to say, is there not a better differential that would explain the patient's symptoms? Question number 4 was, is there a connection between MCAS and ice pick headaches? And if so, what is this attributed to? So ice pick headaches are a rare type of headache, and in the International Classification of Headache Disorders, or the ICHD-3 criteria, it's actually referred to as a primary stabbing headache. And I can't say there's enough data even on that headache disorder. And when you look at, how early we're on MCAS to draw any reliable correlations. So I don't know that there is, but I can't say that there isn't. Okay, so to be continued. That's the best answer that I have. And actually, I just thought of something I did with question number 1 with the high prolactin level, just to jump back to that briefly. When I went over in the slide about neuroinflammation and how there's some activation in the central nervous system, if you think about the process where, for example, cortisol releasing hormone is released by the hypothalamus, you could also make the argument that if there's mast cell activation, in theory, it could stimulate the anterior pituitary gland to release higher levels of prolactin. So if you had a proper workup for all of the usual suspects for a hyperprolactinemia and there was no explanation to be had, it's theoretically possible, but I don't have enough experience in that department to really say more than that, aside than I suppose it's theoretically possible. I did look at that and I forgot to mention it before.
Thank you very much, Dr. McEwen. Appreciate your answers. There's a few questions from the chat. This one's from Melissa. Is there a connection between high IgE and MCAS?
So IgE is not a test that I routinely would use, and it's not suggested in the criteria. Now, if you asked an allergist or immunologist, they would, in the context of testing for specific allergies, I think they would be able to answer that more fulsomely. But certainly, I mean, mast cells have activity in the IgE pathway, so that there is a connection, but I can't speak to as to, how dramatic I would expect there to be a reliable elevation of IgE if we were to test that in every MCAS patient. So I'm sorry, I can't answer that question in any more depth.
That's great, thank you. This one's from Sarah. How do we get more doctors to understand how impossible it is to get tryptase or other mediator testing done in most places? She's tried numerous times in Sudbury. She says, I had to flare during lab hours and they would not follow chilling instructions. What's the point of trying?
Well, so the nice thing with tryptase is I don't believe that's one of the samples that you do need to have chilled. It should be, it's still okay. That's one of the tests, unless somebody with more knowledge can correct me. So I don't have that one chilled, but everything else that I mentioned in that flow chart, generally speaking, does need to be chilled aside from tryptase and chromogranin A. It's difficult because we don't agree in medical circles how this should be diagnosed, and the people who sort of lean more towards the valent criteria certainly are more adamant that tryptase is the one and only major thing. I do think that's shifting a little bit. Because of the reasons I've mentioned, but also really there's a stronger appreciation that tryptase is reflective of mast cell load and not necessarily activity. So I would often suggest just sharing that paper. I really like the Global Consensus 2 paper that I had linked in that one slide as very clear and informative, and I include that in all my consultations back to the referring family doctor or specialist, just to kind of use that as a tool to further educate my colleagues on why I am going outside of or coloring outside of the lines for what many allergists or immunologists view as the main thing. And just to speak to tryptase specifically, there is actually no gold standard with which to compare the essentially random number that they've come up with. It's an expert opinion on what is considered a significant increase over baseline. So we at this point don't have a gold standard. Maybe a gold standard might be some sort of genetic marker someday, I don't know. But I think that's going to have to change, and I would just encourage sharing that paper. Perhaps this presentation might be helpful, sharing the link, but I mean, that's a bit of a stretch, hoping people will watch an hour presentation. So
Thank you for that answer. Question from Paula. I wonder if MCAS could be sometimes responsible for Chiari symptom flares for some EDS patients.
I think MCAS could be responsible for flare symptoms in many comorbid conditions. So the short answer is yes. You have any degree of inflammation in an area that already has a high degree of decreased space and pressure. Yeah, you very well could have an aggravation of those symptoms.
Thank you. Do you have PDS with dystonia?
Do I have
Patients, sorry. Do you have patients with dystonia?
So in my small cohort, I would say, I can't say I've come across dystonia specifically. So I've seen reported muscle weakness. Spasm could be correlated, but I can't really comment on that further, unfortunately.
Understood. Just looking at these questions. This one's from Tanya. The question I always have is how much of patient symptoms derive from HEDS itself as opposed to HEDS being a genetic disposition to these other comorbid conditions. If the symptoms arising from comorbidities may be treatable, it gives us hope for better management and improved quality of life.
Yeah, for sure. So that's a tough question to answer because even as the first speaker alluded, we don't have accurate numbers realistically on, the true frequency of hypermobile Ehlers-Danlos syndrome. We're probably underdiagnosing it. Certainly in my practice, I've seen patients come in with a diagnosis of fibromyalgia who very clearly have signs of hypermobility and may even meet criteria for hypermobile Ehlers-Danlos. So I don't know what that will look like in future. We don't have accurate numbers on MCAS. We don't have accurate numbers on Ehlers-Danlos syndrome. So that's a question that remains to be answered with future research, to be quite honest. So, and then chasing which is which and which drives the other, like that's a very complex interplay of, perhaps what is the driving force of a person's symptoms. And certainly because both can coexist, it sort of sometimes lends itself to a vicious cycle of symptoms. So.
Understood. Thank you. This question is from Natalie. Is it possible to use biopsies collected during a coloscopy to get an MCAS diagnosis? So
yes, you can. Typically what I've read from folk who have a lot more expertise in MCAS is that the biopsies derived from colonoscopies usually have lower mast cell counts than ones from the upper GI tract. So typically the ones where we have the most success are from the duodenum, and then after that it sort of wanes. So, and the cutoff at this point in time is greater than 19 mast cells per high powered field. And when we ask for CD117 staining, we're asking for a count. There's actually probably a lot of work that needs to be done in terms of figuring out what are the standard normals for the general population so that we can actually compare what's abnormal and elevated. And, we're just not there yet. So, but if they have greater than 19 mast cells in a colonoscopy, absolutely.
Thank you. Is it possible the brain diverts pain to other pathways, such as auditory, causing hearing dysfunction, for example? And could this be a path to the reversal of this process?
Just trying to process that. So can you repeat the question?
Sure. Is it possible the brain diverts pain to other pathways, such as auditory, causing hearing dysfunction? And could this be a path to the reversal of this process?
I'm not sure I can answer that question clearly. I would say that it's more the inflammation, not specifically the brain, that's directing any of these responses. If we're thinking about MCAS specifically, there are auditory symptoms in some MCAS patients, tinnitus being commonly reported. I'm not sure about hearing loss. It's possible. And then in terms of recovery, I don't know that it's as simple as just hoping that reversing that one particular pathway will be the solution for that. So I hope that sort of answers that question, at least to the best of my ability.
Okay. More of a general question from Melissa. Dr. McEwen, how do we get an appointment with you? And do we need a referral?
So at this point, really, I'm only seeing patients in Northwestern Ontario. The goal here would not be for me to, set up an MCAS focused practice. The goal with this type of work is to empower other clinicians to consider this as a differential, and especially when you look at the treatment options, is just saying, okay, it's a little unorthodox that we want to use an antihistamine or a mast cell stabilizer to treat pain and inflammation, but that's really what I would like to see. And certainly I would like to see that there is a more national level work to bringing people with knowledge together and supporting these patients. So I'm a pain generalist. I don't only see MCAS, I only assign the diagnosis in my practice when that's the best thing that fits, because otherwise I am here to serve a very underserved remote region, and I don't at this point think I could accept referrals from across the country. So I apologize, that's probably maybe not what people would like to hear, but I will certainly continue to work on simply educating others to consider this as a reasonable differential.
At least you shared your knowledge with us. That's the most important as well. This is a question for Becky. Which meds help you most with pain?
That was part of the problem, is I refused pain medication because I wanted to know what was wrong with me. So, and because of my allergies to NSAIDs and ASA, that was also another issue. So I was taking Tylenol 3s periodically, and I didn't like that, as in I just didn't want to take them, but they helped the best with pain. Happy to report, don't take those anymore. And also, to piggyback on what Catherine said earlier, Tiger Balm. Tiger Balm does work, and I also use mustard oil.
Thank you. Do we have room for one more?
One more, I think.
Sure. This one's back to Doctor. Functional neurological disorders are now officially in disease classification ICD-11. I saw somewhere that MCAS is in the list of differential diagnosis, but can't find reference. In Quebec, we hear more of diagnosed and suspected EDS patients being told they have FND when they experience dystonia or spasms or other crises. Dr. McEwen, are you aware that MCAS is included in list for the differential diagnosis of FND, and EDS should also be on this list?
So I was not aware. I mean, and certainly I'm not a neurologist. My level of understanding of functional neurological disorder is when they've ruled out a definitive neurological cause, and it's felt that symptoms are more functional or potentially psychogenic in nature, that is a differential that should be considered. It's difficult for patients, I think, because it sort of closes the door on potential treatment options or assessment pathways for other differentials. So I'm happy to hear that MCAS is listed as a possible differential. So I have more reading to do.
Okay, we're going to do one last one. Dr. McEwen, do you ever use CBD or cannabinoids?
So I'm open to the use of CBD and cannabinoids. I generally, if patients have already been using them, I will counsel them on the safe use of them. I think that CBD in particular can sometimes be helpful as an anti-inflammatory. The challenge I find with the widespread use is the lack of data, number one. And number two, it's expensive. Most of my patients can't afford to spend, you know, $200, $300, $400 a month for what I might consider a therapeutic dose. So a lot of people will try CBD and say it doesn't work. And if you look at some of the guidelines, so for example, in Canada, the CFPC, the Canadian Family Physician, or the College of Family Physicians of Canada, issued a rough guideline and suggested CBD trials up to 40 milligrams daily. Well, that's actually a higher dose where you'd run through oral CBD products pretty quickly and rack up your bill. So unless you're getting a high concentration, a lot of people will find, oh, it didn't work because they weren't maybe taking a high enough dose. THC, like when we start getting into THC as a component of the product, it becomes a problem in the elderly or people who are at risk for falls or who have psychoactive conditions. So I will consider it, but I feel like it's most helpful in the context of neuropathic pain. But at the same rate, I generally will limit my suggestions to trying things over the counter or prescribing Nabilone, which they may actually be able to get coverage for. So that's kind of my approach. I don't know that it's the right approach, but we still have a lot to learn in the cannabis sphere as well. So.
Makes sense. Makes sense. Well, thank you very much to the both of you, Dr. McEwen and Beckie. I really appreciate your insightful answers and questions.